So in this section this week, we're going to talk about what makes a good assessment. So something that I could think of was that it measures what it's supposed to, and that it doesn't measure what it says that it doesn't. So for example, if we're measuring blood pressure and it's related to our visual acuity, then that's not a very good measure of blood pressure. It should also be repeatable. If I measure my blood pressure and someone else measures my blood pressure, they should get approximately the same value, especially if it's right back to back. And we should get the same result regardless of who gives the assessment. It should be consistent across people who give it. What are some other factors? In the discussion question this week, I'd like you to list other reasons that you can think of for why it's important that your evaluation and intervention in children are done with a good assessment. So one of the ways that we can evaluate this is through something called the COSMIN standards. That stands for the Consensus-Based Standards for the Selection of Health Status Measurement Instruments. Now, what are they? So COSMIN standards has a series of ways in which we can essentially evaluate the scientific rigor of an evaluation. So we look for internal consistency, reliability, over time, between administrators and across items in the test. We look at the measurement error. In other words, is the difference between the measured value and its true value minimized? We want to look at content validity. That means how well the test measures the behavior for which it was intended. The structural validity, how well the questionnaire score reflects the construct that's being measured. Hypothesis testing. So we want to look at if we can evaluate the size and the direction of effect in a random sample. Cross-cultural validity. Can we use the test in multiple different populations and across cultural groups? Criterion validity is how well the tool measurements compare to the gold standard. Now in CVI, that's a little different because they're not different, but it's a little difficult to do because there really is no accepted gold standard for CVI. And finally, we want to look at the responsiveness, especially when we're looking at change over time. Are we able to actually do that? So let's look a little bit more closely at a few of these. So for reliability, this is the degree to which of the result of a measurement, calculation, or specification can be depended on to be accurate. So think to yourself why this is important. Why is it important that we have consistent results across time and that it's accurate? So there is both internal and external reliability. Internal reliability is that the results are consistent between items in a test, and the other is external. That's the extent to which a measure varies from one use to another. So in other words, the test-retest reliability, the inter-rater reliability, and the inter-method reliability. Does it give consistent results with other tests or instruments that test the same function? And it's very important to recognize and realize that reliability does not equal validity. Just because something is reliable does not make it valid. How do we evaluate reliability? We can use a variety of different techniques. Oftentimes it's some sort of a correlation or something called Cronbach's alpha. And the more highly correlated they are, the better the tests are and the better the reliability is. So for test-retest, we look at the correlation between two or more separate occasions. For inter-rater reliability, we look at the correlation between scores from two or more administrators. And it's really important to note that just because we get a high correlation with either of these, it doesn't mean that the test is being administered correctly, only that the test is being measured approximately the same between times. And when we're evaluating reliability, the more items there are in the test, the larger the sample we need. For example, if we have a test of, say, 50 items, we're probably going to need a pretty large sample. So 27 individuals is likely not enough to get a very good estimate of reliability. Validity, that is the extent to which a test accurately measures what it is supposed to measure. There are a lot of different types of validity, and it's important that each type is evaluated. So there's content validity, that is, does the test measure what it's supposed to measure? So for example, if we were looking at math tests, It would not be a very good math test, and it would not have very good content validity if a good score depended primarily on the knowledge of English, or if it only contained algebra questions. Face validity, then, is the ability of an instrument to be understandable and relevant for the targeted population. If we have an evaluation that was used to look at CVI compared to ocular visual impairment, and we use it for CVI compared to other developmental disabilities, well, that might not necessarily be a good use of that test because it was only really designed for the CVI versus ocular impairment. Criterion-related validity is it useful for predicting someone's performance on an external criterion measure? So does a score on test A predict a score on test B? And then finally, we have construct validity. And this is the degree to which a test measures what it's claimed to be measuring, and the ability to make appropriate inferences based off of the observations or the measurements. Within this category, there are three further subtypes: content validity, concurrent validity, and predictive validity. So how do we determine validity? So for concurrent validity, we look at the correlation with existing test measures that measure the same construct. For example, if we're evaluating object recognition, we might look at the L-post and the Leuven 94 or the L94, as well as some other different assessments, and see how well they correlate with one another. There's content validity, and that kind of, we use expert opinion to make sure that are the questions we're asking meaningful and informative. And then there's also predictive validity, so we look at the correlation with predictive outcome. And much like with reliability, we have to make sure that we have a large enough sample, otherwise our evaluation of validity is not very reliable. So what's the relationship then between reliability and validity? If a test is unreliable, it cannot be valid. For a test to be valid, it has to be reliable, and just because a test is reliable doesn't necessarily mean that it's going to be valid. So in sum, reliability is necessary but not sufficient condition for validity. So here's an example. I want you to think about this. So if every day for the last year you weigh yourself at home and it says 200 pounds every day, and then you go to the doctor's office for your annual appointment and they weigh you at 150 pounds. So is your home scale reliable? I would say yes, you're consistently getting 200 pounds. Is your home scale valid? Remember, validity we measure against the gold standard. In this case, the gold standard would be the doctor's office. And we get 200 pounds at home and 150 pounds at the doctor's office. So this is an example of something that is reliable but not valid. It is shy of the target but consistent. We can also have something that's neither valid nor reliable, where it's completely off the mark and all over the place. In terms of the responses, we can have something that's fairly valid. We sort of hit the target, but the responses aren't very reliable and consistent. Or we can have the gold standard then, which is both valid and reliable. We get the measure that we want, and we get that consistently across times. So what's the big deal? Validity is important because if the test does not measure what it's intended to, then the results cannot be used to measure that question. The results also can't be generalized to the findings. And when something is valid, it ensures that the results can be used and implemented effectively. Reliability then is important because if the results are consistent across groups, times, administrators, then changes in that test can be trusted. But if they're inconsistent, we don't know if the change in outcome is due to the test or due to actual change. So for example, if Myself and a colleague both measure visual acuity with an instrument, and I get one measure and my colleague gets another using the same test, it's unclear whether or not there was actually a change in acuity or if the test is not reliable. We can also evaluate sensitivity and specificity. These are measures of classification accuracy, the true positive rate, the true negative rate. We want to make sure that we have a high proportion of actual positives and actual negatives with a low false positive and false negative rate. So here's a way that we can calculate that for your reference. In the literature, this is often shown as the relationship between sensitivity and specificity for a measure is often shown as a region under the curve or the area under the curve, whereby chance performance is at the 0.5 or the 50% line, the diagonal, and perfect performance is along the square. And we really want to be really as close to 1 as we can be, so that we are both sensitive and specific. So why does sensitivity and specificity matter? If a test claims to be 100% sensitive, then it might not be very specific, and we might get a large number of false positives. So tests and screening tools should be as accurate as possible, particularly when it governs who gets an intervention or treatment. So we're going to talk a little bit about the importance of good study design and some factors to keep in mind if you design your own study, and also some factors to keep in mind as we're reading other people's studies to make sure that they were done in an appropriate manner. So how do we go about designing a study? So first, we have our population of interest and also a question that we want to answer. Then we draw a sample from our population of interest and we collect data related to our research question on that sample. Finally, we are able to do some statistics on that sample, and then based off of those statistics, we draw the conclusions about our population of interest. So here are some study design basics. There are lots of different study designs, and all of them are aimed at answering some sort of specific topic or question. The study design that we implement will actually depend on the type of question that we want to ask, as well as the type of data that we're going to collect or that we already have. So the question has to be clearly defined, and our outcome has to be measurable in some way, shape, or form. And each type of study design has its own limitations and strengths, and they vary in terms of bias and overall strength. So let's recap. Let's say we want to create a study. So first, define our question and define our population. And then we have to identify which measurement we want to use to answer that question. And we also have to identify a sample of individuals from the population. Study design is classified broadly on two characteristics. The first is the time period in which the data is collected, and the second is whether or not it uses an experimental treatment or it's just observational. A prospective study is when subjects are recruited and data is collected on subsequent events. A retrospective study is when subjects are recruited and data is collected on prior or past events and exposures. And a cross-sectional study then is when subjects are recruited and the data is collected at a single time point rather than at multiple time points. Multiple time points would be a longitudinal study design. In an experimental study, oftentimes we have one group that gets a treatment and another that's a control. And what we do is we collect information on the responses and assume that the change in response is due to the treatment. It can only be done prospectively. Important to know. Observational studies really only observe the individuals and collect variables of interest. We don't actually have any condition on the subject, so there's no test group and a control group. We just observe. And this can be prospective, retrospective, or cross-sectional. So what are some of the key concepts? First, I like this quote that I found is that any proof of effectiveness cannot be obtained from a non-randomized study. So what does it mean to be randomized? Well, that means that participants in our sample are assigned randomly to the groups. So we essentially heads or tails participant to group A and heads or tails participant 2 to group B, and so on and so forth, so that they're randomly assigned. Another important concept is bias. Bias is any influence that acts to make the observed results not actually representative of the true results. This can occur in many different aspects of the study. It can happen in the design, how the study is conducted, or in the interpretation of the results. So here's kind of a silly example of bias. But imagine that you are doing a study involving patient interviews. Now, how you ask the questions could influence and bias your results. Consider the potential response to these two questions. Do you have difficulty finding your mum in the supermarket? Or, if I was to ask it like this, would it change and lead the answer? You sometimes have difficulty finding your mom in the supermarket, don't you? The second option would introduce bias into the study because it would lead the subject to answer yes, whereas the first was a neutral, so they could answer yes or no. Variability. We want to decrease the amount of variability within and between our groups. Otherwise, it could potentially interfere with the conclusions that we're able to draw. When we do have two groups in our study, particularly if there is an intervention, it's important that the identity of the subjects, whether or not they're assigned to the control or the intervention, are masked. This helps us to avoid bias. And we're essentially not aware of which group the individual is assigned to. And then finally, there's a placebo effect, and it's important to control for this because it can have pretty impactful changes on someone's interpretation of the outcomes. So the placebo effect is essentially that, let's say a control for a drug trial was given a sugar pill, but they still improve in symptoms simply because they were given some sort of an intervention. In this case, it was just a sugar pill, but they still got better. So what are some study designs that are commonly used for interventions? The gold standard in study design is a randomized control trial. So we have our population of interest and we randomly assign them, again, heads or tails, to our two groups. And then they have the outcomes. One gets a treatment and the other does not, or they each get a separate treatment. And then we compare the outcomes between the groups and we draw conclusions about the treatment. In this instance, randomization is incredibly important. It really ensures that any of the changes that we observe are due to the treatment itself and not due to any confounding variables. It allows us to draw cause and effect relationships. Now, what happens when we have two different treatments and we want to make sure that everyone gets the treatment because otherwise it might be unethical? Well, for that we can do a crossover design or a delayed onset design. So for this, it starts out the same. We randomly assign individuals to our two groups, and then we measure outcomes. But then we swap the two groups so that what was the treatment group now becomes control, and what was the control now gets the treatment. And then again, we measure our outcomes and we compare them between groups as well as within groups. This allows every individual to serve as their own control. There are also a number of observational studies, ecological, cross-sectional, cohort, and case control. So in ecological studies, oftentimes this is used for studying at least one variable at the population level rather than at an individual level. And it's often used to monitor population health. It enables us to make large-scale comparisons, for example, between countries, states, or provinces, and it lets us study the relationship between population-level exposure to risk factors. In a cross-sectional design, we are able to measure the outcome and the exposure in participants at the same time at a single time point. So we're able to assess the prevalence of a condition, and it helps us do population-based studies as well as to calculate odds ratios. So one example of an odds ratio is that males have a higher odds of having a beard. So for cohort design, we evaluate the effect of an exposure, for example, exposure to radiation, the presence of a genetic factor, and so on an outcome of interest. So for example, the incidence of cancer. So we can prospectively identify subjects and collect baseline exposure data before they've developed an outcome of interest. For example, the Framingham Heart Study, the Nurses Health Study. And in a retrospective design, we can identify and recruit subjects and collect data after they've already had the exposure, and we compare the outcome of interest. So let's say we compare the incidence of cancer in the Smith family between those with and without genetic factor that might be associated with an increased risk of cancer. There's also the case control design. And here we can compare subjects with a condition and without, and then we compare the level of exposure to factors of interest. This suggests an association between the level of exposure and the condition of interest. For example, we can recruit patients with cancer and those without and evaluate differences in lifestyle factors between the groups that may be associated with cancer. Or, oftentimes in vision studies, we have case control design in that we have our two groups, maybe visually impaired and non-visually impaired, and we look at either changes in the brain or we look at underlying factors that may have contributed to their vision impairment. So here's a great summary table of the different types of study design that you might want to refer to if you ever decide to create your own study. And this triangle kind of shows the different types of studies as well as their study strength and also the bias. So we want studies that are less biased. So we want things that are more towards the top of the pyramid, that are less influenced by opinion. Many of the studies that we do are in the cohort study or the case control study range, particularly in the CVI and developmental condition literature. So what do we need to keep in mind when evaluating the results of a study? It's important to remember that association is not the same as causation. It's important that results are reproducible, either between the same researchers or between research groups. And it's really important that if we're looking at an intervention, that the effects are isolated with a control and an experimental group. If there's only the experimental group, it's really difficult to draw conclusions about whether or not any change in function was due to the intervention itself or not. Likewise, we have to always keep in mind that there sometimes may be learning effects. If we do anything twice, we're probably going to get better at it. And we also have to stay objective. It's important to stay unbiased and blinded where possible. And large sample sizes matter. The power of a big N. If we have too small a sample, we might not be drawing accurate conclusions. So here are some questions that you can ask yourself when you're evaluating a study or a new tool. If you come across a study that looks at intervention, first ask yourself, is there a treatment group and a control group? Is their intervention controlled? Is it similar between individuals? Do they use appropriate statistics to evaluate the responses? Do they use an evidence-based approach? Is there some sort of scientific background to it? And are the outcomes clear and measurable? Can you repeat it? When you're looking at a new tool, ask, does it have clear and measurable outcomes? Is it based on evidence? Is it reliable? Right? Are the results consistent over time between administrators and across items? Does the test measure what it's supposed to? Does it have good content validity? Do the questions asked actually reflect the construct that's being measured? Does it have good structural validity? Is it appropriate to use in my population? How does it compare against the gold standard? And is it able to detect meaningful change over time without the influence of bias? And finally, can it be used to test a hypothesis? I hope that these are important things that you can keep in mind as we come across new tools for CBI in the literature. And hopefully these will be useful for you in the future.